Very good morning to one and all of you in this audience and the moderators on dais. I know I'm jumping the queue because I need to go back to my ARC programs, and thank you so much for this permission. My due is to talk on refractive lens exchange, when to do and when not to do. I think this is a very relevant topic because there has been an increasing interest on the part of the patients to get rid of their glasses. And they know that we have the technology for it, but are we allowed to do it, or are we going to burn our hands? Because the refractive lens exchange is not a treatment of pathology here, but rather it is about improving the visual performance. So the whole concept is different here. We do know we have the advanced biometry, we have the beyond the 4th generation formula which are available, which is getting us close to immetropic outcomes. We are lucky to have the laser refractive cataract platform also. I do not say that that is the only way you can go in for a clear lens exchange, but the criteria is you have to be excellent surgeon and you should be evaluating your post-op visual outcomes, and you know that you are consistently hitting the target. Then you are poised for a clear lens exchange. And we do have premium IOLs today, which of course we have to titrate to the requirement of the patient. The three main categories where the patients may be interested are the low ametropes and presbyopes, those with very high refractive error where you cannot do a laser vision correction, or the AC depth is not adequate for an ICL, or those post-LASIK laser vision correction patients in the presbyopic age group who are anyway not wanting glasses, and now with the blur setting in, they are very much keen on getting a clear lens exchange. And are we justified to do it is the question. We have to really look very carefully at the ocular surface, be it the treatment of the dry eye status or anything which is there. The meibomian gland, which is not optimal, has to be taken care of. We need to look at the lens, the zonular status. We have to have an OCT done, look at the retina. And we need to understand that biometry is actually just a simple arithmetic. While there are some accurate measurements, there are a lot of assumptions here. Like if you see, when you're planning an IOL power calculation, the first thing which pops up is the axial length. Today with the optical biometers, we have unsurpassed accuracy. But when you feed in the post-op refraction which you want, the other variables which come up are the K which has to be entered and the effective lens position which has to be mentioned. We all clearly know that we are nowhere close to getting at the absolute accurate K measurements, and also we are off in our effective lens position, although the newer formulas have got more and more variables which tell us to get that close to assessing the effective lens position. For that we have the better formulas like the Barrett Universal 2 or the Hill RBF, and we have the facility for using the best of ocular biometers, optical biometers. So this is the first case scenario wherein the patient had a small refractive error for distance, but essentially he was not very comfortable for his intermediate vision and needed glasses for near vision. Then when you have an access to eye trace, how it helps you is that it has a component called the dysfunctional lens index. And if you look at that extreme right, that dysfunctional index less than 5 is the patient who would be having some amount of visual blur, scatter of light, lack of clarity. And this persistent patient who keeps coming back to you wanting to get rid of glasses, for all you know, he may be having that kind of a lens, dysfunctional lens index, where there is a quality of vision which has already sort of started going for him, which may urges him to come to you. And if you have an eye trace and it tells you that the dysfunctional index is 3 or 4, that might be one more reason to kick you off towards a clear lens exchange. We need to look at the amount of astigmatism, and the least amount of astigmatism needs to be corrected in these patients because the promise is to get them rid of glasses. If you have access to the laser cataract surgery, it's a very soft, nearly absent cataract or very early cataract. So you could plan a honeycomb kind of thing wherein you're not doing much of softening here. And you can see that the anterior chamber is completely stable. I'm just prizing apart the fragments which are already ready to be engulfed, and there is hardly any manipulation in there in the eye. Of course, we have the best of phaco machines today, which also keeps the anterior chamber stable. But more than anything else, there's literally this patient had a CD of 0, and we were able to place the lens in this, do the surgery, place the lens. Of course, you need to do a thorough cleanup. Viscoelastic has to be removed. The lens has to be centered to the Purkinje reflex. We should see that you have the ideal rexes overlap over the lens, because everything attributes to getting your optimal results, and the patient did well. Now, this is a second case when he's a very high myope. He had an inadequate anterior chamber depth for an ICL, and you could not do a LASIK in this case, and he was very much interested. You need to do a thorough retinal evaluation, and before you can even think of doing a cataract surgery in these eyes, and probably this is an area which I would never transgress easily unless, of course, he has a PVD. But that doesn't mean that if he has a PVD that he is not going to have a retinal detachment, but the PVD is sort of encouraging. If he has a posterior cephaloma, you need to ensure that you use your optical biometers, because with the immersion you might measure a higher axial length. So, however, the good news here is these IOL parts are very small IOL parts. So, even if there's a little error in these lenses, the effective lens position is not so significantly impacted as it would be if you were to use a very high part IOL. But there are surgical challenges. This is a deep anterior chamber, and the cornea is large, so you might erroneously make a larger axis and you could have an optic capture. You should go in with your infusion off. You should increase your IOP ramp. You should be prepared for a reverse pupillary block kind of situation. So that is why you should go in with your infusion off. You can just lift up the iris and that would release the pupillary block. Then you could do a hydrodelineation, because these are very soft cataracts. So you have an epinucleus, endonucleus, which easily comes off. You should do a thorough cortical cleanup. You should do a capsule polishing. In a high myope, you may have to place a CTR2, and all of these are very much mandated, and over and above, you can plan a toric IOL. The challenge is if it were an extreme axial length, a small eye, these are very high powered IOLs. A small change in the IOL can bring a huge refractive exchange. And in short eyes, we are never sure whether it's a shallow AC or a normal AC. That's a challenge there. We need to use adequate viscoelastic, but not overinflate these small eyes. There is possibility of positive vitrate pressure, so you should decongest these eyes. And you may have to customize IOLs or even plan a piggyback IOL. This particular patient had a 40 diopter IOL implanted in both eyes, but in the left eye, he ended up with a 6 diopter of residual. So we use the Nichamin's formula, wherein you need to multiply by 1.5 and a plus 6 diopter needed a 9 diopter lens. And so a large optic sulcoflex lens was planned, which has undulating haptics and a posterior curvature, which ensures there's a space between this and the primary lens. And the haptics of this lens has to be placed at right angles to what the original IOL was placed. The last slides I'm showing you. The third segment is a post-laser vision eye. He is very keen on getting a clear lens exchange, but you need to understand that 70% of our patients may have no dry eyes, but those 30% where the standard deviation is more than 2, you need to check for dry eye status. If there is dry eye, treat the dry eye before you promise to do him a surgery. You would have to do not just a routine topography, a tomography, because there's an altered ratio of the anterior-posterior curvature. You have to use the best of the formulae and the toric IOL. You need to do a posterior segment examination, because these are high myopes, cannot be missed out. If you have access to eye trays, rule out higher order abrasions. Look at the angle alpha. Of course, with the modern lenses, the central optic zone is larger. So they do tolerate even an angle alpha more than 5 to even up to 8 is tolerable. But the higher order aberration should not be there. The cornea should be regular in the 3 mm optic zone. The topography has to be normal. And there is astigmatism in this eye. So you need to correct the astigmatism. And a trifocal toric was done for this particular patient, because he was not very bothered about the light dysphotopsia which is seen in these diffractive lenses. But he did very well, and with the Varion overlay or any other imaging device, you would get near optimal. Most importantly, if it is a LASIK patient, you need to go to the LASIK mode, use the Barrett, Truquet, TK, the latest formulae, and that is what is important. Finally, we have to be with the patient, look at the raw data, validate the measurements, choose the best formula, treat the astigmatism, look at the different choices of IOLs we have, and choose the right IOL which that patient is going to need. So it has to be the right patient, the right IOL, a perfect surgery. In that particular case, maybe a refractive lens exchange could be one of those choices you could offer to your patients to get him off glasses. Thank you very much.